Good evening, everyone. I'm Dr. Ashish Gulve. I'm the President-elect of the Neuromodulation Society of UK and Ireland. Along with me, I got Barani, who is the current president of the NSUKI, and we got four excellent panelists. Ms. Tana Bohanik from Oxford, Dr. Philippa Armstrong from York, David Pang from Guy's and St. Thomas's in London, and Mr. Girish Vajramani, consultant neurosurgeon from Southampton. We developed guidelines on organizing neuromodulation services during COVID pandemic, and we did publish those during the beginning of the first wave of the COVID. Society then published another guidelines on resumption of services as we were in the COVID recovery phase. Unfortunately, now some parts of the country are back into the second wave, and we wanted to share our experiences, what we learned from the first wave and how to navigate the second wave and keep providing services to our patients and taking care of our patients. So that is the purpose of this webinar. Before I open up the webinar, I would also like to announce that NSUKI is going to organize another webinar on 23rd of November at 6 o'clock UK time. And this will be addressing the role of placebo-controlled trials in neuromodulation. We will send you the details in a day or two, but you can note the date for diary and the time for your diaries. So this is on 23rd of November at 6 o'clock in the evening. So with that, I think we got reasonable numbers who are now been able to join us on the Zoom meeting. So I will request Tana to tell us about how to maintain intrathecal drug delivery service during COVID pandemic. So off to you, Stana. Can you hear me?
Yeah. Thanks, Ash. I'm going to just try and screen share everybody, and hopefully you can see this. Good evening to everybody. I hope you're all well and safe. So the remit for tonight is lessons learned in COVID and navigating the next wave, which is already upon us. And I'm very mindful that we work in different areas of neuromodulation and in different departments. So in neurosurgery in Oxford, all of the neuromodulation consultants, together with all the neurosurgical consultants and specialist nurses, were in the hospital throughout COVID. And I think this made it easier for us to maintain a service because we were here due to urgent emergency admissions for neurosurgery and also helping out with COVID. So for example, our SHO tier was all redeployed from very early on. I think it has been a challenge, and one of the things I'd say, I think we all have this experience that we have had to adapt and virtually week on week change what we do as we've received new information about PPE and COVID. So I think we're all going to have slightly different experiences. This is ours, and I'd be very interested to hear about all of your teams. One of the things that happened from very early on is our theatre capacity was cut. And we went from running 3 lists a week, Monday to Friday for neurosurgery, plus weekend lists, to 3 lists a day to 2 lists a day, Monday to Friday, no additional operating at weekends other than emergency operating. So an MDT approach is something that's banded around, but from early on, we all met as a team, and really we wanted to decide and prioritize what was essentially important in our service and the things that we had to maintain. And sorry, my slide is not going to move. So we divided these into essentially these groups. The first thing we thought about was essential maintenance of pumps. So things that we simply had to do, refills and pump changes. We then thought about outpatient support for patients, carers, GPs and staff. We looked at ongoing assessments in the pathways, and then we thought about new implants. And of course, at the end of it is reviewing what we do and our learning curve in COVID and what we would improve next time round. In terms of essential maintenance, in February, with the wave sort of looming, we decided that one of the things to do to give us a breather was to look at our list for the next 6 months and to admit over a 2 to 3 week period all of the pumps that needed to be changed within the following 6 months. And the pre-op assessment and team were pretty amazing in doing this. And pump changes are a bit like buses. At that time, we only had 4 or 5 to change to give us a breather till the end of September. So those patients were admitted. That gave us a bit of a breathing space. As things opened up in September in our unit, we've then done a second wave of pump changes, which should take us through to the end of January. And that's something that we're constantly reviewing. The refills were slightly more difficult because we can't stop refilling pumps with opioids and baclofen. And the refills, we were very aware that this is an outpatient service and we were trying to separate areas of the hospital. So the way we managed this was, as outpatients was not receiving face-to-face consultations other than emergency cases, we redeployed our refills from the day assessment part of the ward to outpatients. And this enabled us to have, if you like, a green outpatient pathway in the hospital where we had more space, we had more control of appointment times, where rooms could be cleaned adequately in between refills, and where there was more space for waiting, and we really could limit the footfall in the hospital. So our 2 specialist nurses that run the refill clinics have been amazing, and that has run really well, moving that to a different part of the hospital and having real control over how we run that. One of the things with refills that we encountered, and I don't know if other units have encountered this, was a shortage of intrathecal drugs. Now, that wasn't so much with baclofen, but certainly with some of the opioid concentrations, we found not immediately, but in about July time, we were really having problems sourcing that medication. So several of our patients had to be refilled with different dose concentrations with bridging therapy. And one of the thoughts I have that I'll come on to later on is how maybe we can look at that as a national team to maybe improve that. The pharmacists were really helpful, but I say we had a little bit of recalculation to do with some of the opioid medication. Without patient support, we were very aware that we wanted to respond as ever very quickly to any concerns, because we didn't want things to escalate to GPs and emergency departments. So we immediately transferred all of our assessment follow-ups instead of face-to-face to telemed clinics. But we were very prompt in replying to email inquiries, telephone inquiries, trying to diffuse any situation and then make decisions as to whether we needed to see patients. Equally, outpatient support is looking at new referrals. And we made a decision fairly early on that we wouldn't stop prioritizing new referrals. And so for any new referrals for assessment for a pump, we contacted patients and carers to offer them telephone appointments, but very clear at the beginning that this service, in terms of actually undertaking intrathecal test doses and putting in new pumps, was on hold, but we were happy to start the process of speaking to patients, running through what assessments would involve and running through the pathway. And interestingly, about 70% of people who were offered that did not want a telephone consultation even. They just wanted to wait until we were up and running and come to a face-to-face consultation, either themselves with carers or family. About 30% still wanted a telemed consultation, and therefore we undertook those. Ongoing assessments in the pathway are slightly more difficult. So they're patients who, for example, have been sent for scans, have been sent for gait lab analyses, have maybe had a test dose, aren't sure about whether they want to proceed. So with those, again, we primarily just went to telemed consultation, but quite a surprising number of those patients, despite being offered telephone consultation and attend anywhere consultations, actually wanted to wait. Now, I think probably in the second wave, people will be less inclined to wait, partly because they've already waited already, and partly because I think the perception is in some parts of the country, the second wave is not as severe. Whether that's going to be true or not, I don't know. The thing that we did put on hold and that we're finding frustrating at the moment, we know that patients are, is we elected to not undertake any new test doses or new implants. And this was partly because of capacity and partly because of what we were already doing in the hospital. So we receive urgent and emergency referrals from 10 hospitals with regards to neurosurgery. And we felt that it just wasn't appropriate when we had patients, most of which were on an amber pathway coming into hospital, but where we are included in the trust escalation policy for a red pathway to then admit new patients for implantation. And actually losing a third of our theatre capacity, in all honesty, our theatres were full with emergency and urgent cases. We did explore looking at other hospitals in Oxford which were purely on a green pathway. You may have had this experience as well. Our experience was those pathways were designed mainly to try to fulfill services for paediatric, cancer and cardiac patients. And what we found when we investigated maybe admitting to other hospitals is actually they were at full capacity for those specialties, and already a lot of their staff had been redeployed. So they were not at full capacity and the capacity they had was saturated. So in the short term, we decided not to put in any new implants or undertake any test doses. And at the moment, we are still in that position because now we're on catch up with urgent tumour cases and neurosurgical cases. So that just gives you an overview really of decisions that we've made as a team. I think the thing about looking back on anything is hindsight is a beautiful thing. And one thing I would like to say is I'm very proud to work in the NHS because I think everybody in the hospital, the whole of the team and all the subspecialties worked really well together. Consultants now in neurosurgery know how ventilators work. You may find that quite frightening as anaesthetists, but we decided that we were going to volunteer for everything. We did all of the courses. Every week PPE and COVID was changing and people adapted very well. I think if there are things that I'd like to change and I'd like everybody to think about really, one was the intrathecal medication supply. There weren't hiccups with baclofen, but there were some hiccups with opioids, and it's not something you can stockpile on a shelf with a very short shelf life. I don't know if there should be a better network between hospitals and pharmacy departments and looking at supply chains for that medication. I know we have the Intrathecal Baclofen Forum, we have NSUKI, we know sort of as a group where people are implanting pumps and undertaking refills, but I wonder if we need a more formalised network so that that phone a friend is very easy to everybody. I think the specialist nurses have a very good network, and that certainly was very helpful in nurse-to-nurse dialogue. And I wonder if we need just to expand that in the face of a situation like this again. So that would be one of the suggestions I would make. Maintaining the new test doses and implants is still a challenge. Our theatre capacity only this week has gone back up to normal. We are on catch up with urgent cases. We have started doing some more maintenance. And the reason we're doing that is partly because of theatres going up to 100%, but one of my colleagues, James Fitzgerald, has worked very hard to get us an extra neuromodulation list in one of the university research angio rooms. So we have tried to be innovative. We've looked at the private hospital locally to see if we can extend neuromodulation lists. They are still contracted to NHS work for 75% of their time between Monday and Friday, and things may change again. We've tried to look at other hospitals in Oxford, but they're in the same situation with needing to catch up with urgent work, staff coming back, and again now being pretty saturated with what they're trying to do before the next wave really hits in Oxford. So that's my overview and some thoughts. And I assume, Ash, are we going to be taking questions at the end?
So we will take questions at the end. But what I would like to ask all the participants is type your questions in the Q&A box that you have at the bottom of your Zoom screen. And then we will have a nice panel discussion at the end of our webinar. So please type your questions and we will pick those questions up, because that is much easier way rather than asking live questions. So keep on typing your questions and we will address those at the end of the webinar. Thank you, Stana, for excellent thoughts and insight into how you coped with intrathecal services in your hospital and in your region.
Thank you.
Now I will invite Philippa Armstrong from York to tell us about how they managed SCS services in York.
Okay, good evening, everyone. I'm going to try and share my screen. Oh, sorry about this. I'll just try and get it to the beginning. Hold on.
Philippa, if you go on that, go to slide.
Yeah.
Yeah, or
Okay.
just start from the beginning. Yeah. So if you just click on the top. Yeah.
Yep, got there. Thank you. Good. Okay. So good evening. I'm Philippa Armstrong. I work at York Teaching Hospitals, and I've been asked to deliver a talk tonight about the impact that COVID had on our spinal cord stimulator service, specifically aimed at what we learned in small centres. So, this is our catchment area. York is down at the bottom here, and we have quite a large geographical area. It's York and Scarborough, part of the same trust now. There's 40 miles between us. You've got Hull about 50 miles away on the coast to the southeast, and then you have Leeds about 30 miles away west of us. So that's where we sit. We serve a population of about 800,000. And we receive between 2,500 and 3,000 referrals a year. We've actually had a pain service here for a number of years, and I think it was Ray Marks who implanted one of the first SCSs back in 1979, who was a consultant here in York. We've had a full MDT service since 1998, and our interventional service includes intrathecal spinal cord stimulators, DRG stimulators, as well as the usual set of injections. We've had various developments over the years, and we specifically set up a spinal cord stimulator pain management program in 2014 because we felt that many of our patients who were awaiting spinal cord stimulation, it didn't sit that well within the pain management program that we were running. Caused a few problems with those who weren't awaiting spinal cord stimulation. So we decided to separate the two out and run a specific pain management program for them. And we've made a few adjustments over the years. Again, in 2017, we managed to create an all-day theatre list, which helped with trying to get the interventions done a little bit more proactively. We increased the number of information sessions that we provided through our SCS PMP. So we had a 4-week program for everybody who was being evaluated for spinal cord stimulation, which we then decided to hive off the first week and just deliver information to patients about what it involved and what the expectations would be. And the idea behind that is that people would be able to make informed consent as to whether they wanted to go forward with it before we'd sort of invested a huge amount of time with the PMP, and in fact they could divert off into the standard PMP instead if that was deemed to be more appropriate for them, if that's what they would require. We've also set up screening questionnaires as well, so that we can identify people that probably need a bit of extra psychology before they get considered for spinal cord stimulation. Presently we have 5 consultants now as part of our team, 4 of whom are implanting. All of us are part anaesthetist, part pain consultant, so we're not all full-time except for Peter Hall, who's now full-time pain as opposed to doing any anaesthetics. And we've been implanting about 50 to 60 patients a year, so that's where we stand. I thought I'd give you a little bit of background of what our setup was before COVID, so you could understand the impact that COVID has had. And this is our standard pathway, which obviously it's kind of far too busy a slide for you to all to take in, but on this slide, the idea is that everything in red is meant to be patients who are not going to proceed any further through the pathway. The amber is people still need a bit more time to decide if spinal cord stimulation is for them. And the green is basically people that are looking good and will proceed forward for being suitable for spinal cord stimulation. We evolved this pathway because we felt it's really important that patients have to buy in and engage in spinal cord stimulation for it to be successful. And we felt that the decision for people actually getting implanted should be a shared decision, not just by the consultant, because we often don't have enough time in our consultations to really establish whether somebody is suitable. And we hope that by setting up this pathway, we would reduce inappropriate implantation. And obviously it also fits with the NICE guidance. So when patients are first seen by the consultant and decision is made that they probably could benefit from spinal cord stimulation, they are then invited to join an information session, which was normally delivered by a couple of members of the team and one of the implanting consultants. And then they were given questionnaires. These questionnaires included the patient catastrophizing score, PADS, EQ5D, the Oswestry scale, and BPI. And they were to complete these questionnaires and send them back, otherwise they wouldn't proceed any further down the pathway. When these questionnaires are received, we then assess them, or members of the team assess them. If they have a PCS score greater than 30 and a HAD score in either anxiety and depression greater than 11, then they were taken off from the group and I'm given the option of some individual psychology prior to proceeding down the PMP. We've had this going now for at least a couple of years, and we noticed that when we introduced this pathway, that there was about a 30% dropout rate of patients, those that were referred by the consultant into the pathway. And we actually thought this was a positive. This shows that there are a number of patients that decide that actually they're managing without the spinal cord stimulator, and they prefer to proceed without it. So pre-COVID as well, our pathway was that all our spinal cord stimulators are done as day cases, and they're all done under local anesthetic. We included DRG stimulators in this to start off with, in the belief that people were hard in Yorkshire. We realised that they're not quite as hard as they say they are, and we've needed to adjust that, and we use targeted sedation for our DRG stims. The reason why we made the decision for them all to be done under local, not only because in fact almost all of them tolerate it absolutely fine, it actually allows more efficiency of list, and it means that we didn't need to request an additional anaesthetist from the anaesthetic department. So listing became a lot easier as well. But as I say, we've had to go back on that with our DRG stims. Our pathway also is one where we do stage 1 trial with a permanent lead, and then bring the patient back within normally 10 days to 2 weeks later. And if it's been successful trial, we would then remove the external part and then just implant with the same lead, percutaneous lead in place. So that's the setup pre-COVID. We were doing pre-COVID between us all about 5.5 theatre lists a week. And when COVID struck, well, like everybody else, we had sudden reduction in our capacity. It hit York really in mid-March. Like most other people, we decided on the 13th of March that we should probably stop our outpatients face-to-face appointments. And our elective lists for all elective work were stopped for us on the 23rd of March. As I said earlier, 4 of our consultants are also anaesthetists, and we were all redeployed into ITU, and we had a couple of weeks work up in ITU to try and become current again, and all our MDT staff were redeployed as well. So what we did manage to keep going though is we had our one consultant who the anaesthetic department suggested that they would wait to see whether they needed to bring him back to anaesthetics, or then until such a time he could continue with pain management. We were able to continue with an all-day theatre list over at the private hospital. This was for local anaesthetics only. We only did urgent procedures on that, and we classed our urgent procedures as refills of intrathecals, palliative cases, so intrathecal insertion, acute backs. We have an acute back pain service here in York, so acute back injections, including the option of steroid transforaminals or local anaesthetic only. And we continued with some of our treatments for CRPS, which is something that we also use regional block and physio with. Our consultant carried on doing new patient clinics, just 1 clinic a week over the telephone, and he took on all the follow-up clinics from the other consultants, also changed to telephone. As I said, all our MDT staff were redeployed except for one of our physiotherapists who worked alongside our consultant, turning up to the lists as well, so that all patients could be examined pre any intervention, and they could be given physiotherapy advice as well, as particularly for the acute backs on the day. Our psychologists were able to continue and were very quick at setting up their virtual clinics. They weren't taking any new patients, but they were managing to continue with a number of the follow-ups that were already in the system. So for 2 months, that's the way things were. And then, fortunately for us in York, the surge was not quite as bad as it was down in the south of England. And we were allowed to return back to our normal jobs in May. I was assigned back to pain from the beginning of May, and then slowly we managed to get our MDT staff back as well. So we spent quite a lot of time in May and June trying to work out how we were going to manage in this new socially distant way. and how we were going to set up our clinics so that they would be secure for perhaps a second wave. At the beginning of June, we were also fortunate in that one of the other independent treatment centres in York became available for local anaesthetic lists only. The reason for that was that we did not have enough anaesthetic cover to cover off-site centres, but the staff in these places were keen to be involved and help. So many of the lists were used to manage the plastics and the max-fax cancer patients that could be done under local, but also we were able to use 3 all-day lists for our pain patients. We use this time to train our staff in Attend Anywhere and request the necessary IT equipment that we desperately needed to upgrades that we needed in order to deliver virtual clinics. In July, we set about creating videos for our virtual SCS pathway and continued to wait for additional IT support. And in August, we actually delivered our first virtual virtual SCS group, and we were given notice that the national contract for the independent treatment centres was going to be extended. September, 2 of those lists that were in the independent treatment centre closed down, but by this time York Hospital had managed to get its day unit back up and running, and we were able to move 2 of those lists back into York Hospital, which gave us the availability to do some general anaesthetic procedures on occasion, not that frequently. And we also managed to get our virtual new patients commenced. And that's really been ongoing in October. We are waiting to hear what's going to happen in December when the national contract runs out again, and they're trying to undertake some local negotiation for ongoing support from the independent treatment centres here. So during this time, with having the good fortune of 3 all-day lists under local, we were able to put through not just our urgents, but also our long waiters. So the spinal cord stimulators were also able to be done. What did we do for our virtual spinal cord stimulator group? Well, every patient that was on the waiting list was phoned. They were informed that they were still on the waiting list and that we were planning this virtual SCS group, and we made sure that we had an email address with which we could communicate with them. We created 5 videos, which initially it was difficult. We're not the most tech savvy, that's to be sure, and it took us a while to work out what to do with the help of a lot of teenagers, really, to give us some help. We started off with MP4 videos that we put onto memory sticks and then sent them out to patients, but then to make it more cost effective, we then changed this to an unlisted YouTube video, so that you can only access the YouTube video if you are given the link. So we would tell them the link, and then they could access these 5 videos. And these 5 videos involved a 2-minute introduction to the team and what the expectations were, a description of the B-Temp approach, which stands for behavior, thoughts, environment, mood, and physical. 3 videos that were recorded by the consultant who would normally have delivered those in person about what is an SCS, who is suitable, and what does the procedure involve. So when they'd watched those videos, they were then invited to a WebEx question and answer session, and the questionnaires that we had previously been sending out, we still sent out, and we told them just to watch out for them in the post. The WebEx question and answer session was held by one of the implanting doctors and a couple of members of the team as well. And patients had the option, obviously, to just talk through what the videos meant to them and if they had any questions from it. Following on from this, they were told they had to return the questionnaire because without that, there's no engagement. So they are encouraged to return the questionnaire before they go forward to the program. And we still run the same 3-week program, but we run it virtually. So patients are then sent further video links and invitations to a weekly WebEx. The first week of that virtual program, all the patients are online. They introduce themselves. There's a little recap of the videos that have been sent out. And their videos include medication management, physiotherapy expectations, and an explanation of the psychology concepts. So psychology concepts being based around what they call the 5 Ps. Now, anyone with a military background would think that stands for something else, but what they've told me that stands for is presenting problem, predisposing factors, precipitating factors, perpetuating factors, and protective factors. So it's an introduction for the patient of how to manage their pain alongside the spinal cord stimulator. In week 2, there's a little bit more activity. They actually have an activity management information session, and there is a relaxation session conducted over the internet, and a stretch session as well. And then in that week, they're also asked to start to consider what their goals of therapy post SCS are going to be. The week 3 part of it has been changed into individual telephone calls to each patient, so that they can identify specific goals for each patient. They can have a medication plan, and then there are any personal questions they didn't necessarily want to share over the group session. So that's the way we have been conducting our virtual SCS since August. And we have run 4 of those sessions so far, and 1 full group. So 4 information sessions and 1 full group. Our interventions during this time, when we only had local lists, all our DRG SCS were offered a standard SCS or wait, and in fact, all of them chose to go standard SCS apart from 2 who are still waiting at the moment for the lack of availability of general anaesthetics, lack of availability of anaesthetists. We changed from a stage 1 and stage 2 to all SCS being done with an on-table trial only. And the reason why we did this was for a number of reasons. Obviously, reduced number of day case visits, reduced exposure to COVID as a result, and a reduced risk of inability to complete should we suddenly find we are without lists, and that other specialties' urgency has increased. I at all times did make sure that though we had 3 all-day local lists assigned to us in pain, that if there was any other specialty that felt they had more urgent work, then we would be happy to move aside. So that was a possible risk that we wouldn't necessarily be able to complete if we just did it as a stage 1 and stage 2. We also based it obviously on the information that Simon Thompson presented at INS in Nijmegen about cost effectiveness of on-table trial or no trial compared to trial, and the recent study that was published in August of the trial STEM. So, lessons learned. It's difficult this because I don't really think we've had enough time to really know what lessons we've definitely learned for a second wave. We're still learning as we go. We have learned that virtual clinics are extremely hard work for everybody, not just clinicians, but patients. And it takes an awful lot of input to make sure that everybody's online, can get on board. And for the future, we definitely feel that we need a tech helper to prevent clinicians having to spend time helping people on or phoning them to find out what the issues are. This hasn't happened yet, and I think we're going to see if we can try and tap into the thousands of NHS volunteers that were supposedly around to see if maybe we could get one of those, as we've been told that there isn't anybody else available at present. We've also identified the fact that it's much harder to deal with large groups when you're online trying to identify their needs. So smaller groups are needed because each person takes an awful lot more time as well. There is, of course, the possibility that you think if somebody can't get online for a WebEx meeting, does that mean that they're not necessarily going to be able to manage an SCS either? I think that's probably a little bit harsh, but there is an argument for that. The team have fed back at the moment that they're not sure it is as effective an assessment as having people in a room together. And this obviously is because an awful lot of our assessment is done through non-verbal communication, how the group interact with each other. And that is very difficult, if not impossible, when people are online. When people are quiet online, it doesn't necessarily mean that they are inhibited in real life. It might just be that they're really struggling with the tech or they're not very confident with it. We've also noticed that there seems to be increasing need for psychology. Now, it's too early to say whether this is due to a general increase in distress in the population due to COVID, or if the consultants who are referring onto the pathway have got a broader criteria than they used to have. Our esteemed colleague, Dr. Peter Toomey, had a classic phrase that he said it was the Toomey cup of tea test, and that's very difficult to identify when you're just online with someone rather than being in the same room. His comment was that if you couldn't take them home for a cup of tea, if you wouldn't take them home for a cup of tea, then you probably shouldn't be putting an SES into them, which was quite a valid argument in many ways. We think we need more feedback from the patients that aren't turning up to these. So we had about 30% dropout pre-COVID or thereabouts after the groups. We haven't done enough groups to know what that dropout rate is going forward. We know that we've had about 10% of people post the information sessions that we've delivered, not move forward to give back their questionnaires. But that's too early really to say, is this more buy-in from patients this way, or is it that we're just not being able to appropriately assess them? So lessons learned from the whole second wave. What we did notice is that the expectation initially, particularly for myself, is that everyone was going to be really busy, and we've actually found out that not everybody was. We were lucky in York in that we had these independent treatment centres that didn't have anaesthetic cover, but an awful lot of staff who were willing and very keen to get involved. So we were able to tap into that. Liaising with the anaesthetic department has been incredibly helpful. Being anaesthetists as well as pain consultants, I think, has helped because we have those personal relationships with the team, so that they have been very good to us about trying to allow the service to get up and running. And they have stated that when we need to redeploy again, we will be the last anaesthetist to be redeployed. Communicating with everybody really has been really important as well. Regular team meetings. We've had monthly strategy meetings with the team. Just constantly trying to prepare for the next issue or the next problem, and just being ready for it. A lot of patience with IT. That's been not just the fact of your own inability to manage it, but also the amount of resource has been very limited because they've been so stretched themselves. And trying to preempt the inertia of the system. Everything seems to work so slowly in the NHS. That's been my impression. And sometimes you have these great ideas and it's so difficult to get them started and going. So what you need to do is just make the best of what you've got at the time and just be ready to change tack as and when others catch up. And most important, of course, is appreciate your team. It's like Stan has said, I'm really proud to be working for the NHS. I'm really proud to be part of the York pain management team. They've really gone above and beyond to try and keep this service running, and it has required an awful lot of extra work, but hopefully we're in a slightly better position now, should we get a significant surge, and if we can keep our team in place. And then just a little picture from the great motivator Bear Grylls. That's me finished. If I think again, like Sana said, Ash is going to take questions at the end.
Thank you, Philippa. Please type your questions. We got one question. We'll come to that in our discussion part at the end of the today's webinar. But please keep on adding questions to that Q&A tab that you have. So next, I will invite David to tell us about what was his experience at a large busy center with regards to spinal cord stimulation. David, off to you. You are muted, so if you unmute yourself, David.
Right, can everyone hear me now?
Yes, we can hear you nicely. Yeah.
Right, let's start. So thanks for inviting me. I'm going to go into more of an overview instead of details. I think anyone who wants details can ask me questions at the end. I'm more than happy to answer. So my name's David Pang. I'm one of the consultants at Guy's and St Thomas's in London. And I'm just going to share our experiences in a sort of larger centre, although saying that, a lot of what I will say will overlap, and you'll kind of see a lot of familiarity, but hopefully there's a few things different and give you some ideas. The main 4 things that we looked at trying to do is maintaining not only our service, but also what do we do about the new referrals, and also 2 areas are research and teaching that we do, and how do we balance all of these 4 when in the middle of a lockdown. So our service is quite a big service. We see about 5,000 new referrals in total, and we do about almost 200 new implants. These are these are batteries really, and about 450 procedures. That includes all our trials and revisions, etc. We also run a pre-implantation pain management program. So similar to what Philippa does, this is a sort of bespoke SES program for our patients, separate from the main pain program. And what's interesting is that ours is residential, so that all got really restricted a lot during the lockdown because of social distancing. And we also, when you see a lot of patients, you accumulate them under follow-up. So what do we do about those? So again, in the middle of lockdown, we all switched to telemedicine. We did have an emergency service in the main theatres. So in the sort of in the beginning, we had a case who had an infected implant, and we had to book an emergency slot in the main theatre to take it out, which was quite a challenge, but we had to do it. And we also lost a lot of our staff. So our consultant body is about 10, and about 5 of the staff had to go to intensive care and anesthetics, myself included. It left a few of the senior staff who we kind of kept, say, at home to do telephone clinics. And what was interesting was that because we lost all our theatres and procedures, that waiting list went up, but the actual outpatient waiting list went down because we maintained a telephone clinic. And this is a theme again, I'm going to go into a bit detail later. A lot of what we did to get back was based on risk assessment. And I suspect this is something similar to what everyone's doing, but we kind of focused on this a lot, even in the middle of the lockdown, just to try and see what patients can we bring back when it all goes over. So again, new referrals, we saw much decreased amounts of referrals during lockdown, but we tried to maintain the virtual clinics. And we saw this interesting knock-on effect where pretty much Monday to Friday, we just did clinics. There was no theatres. So our outpatient capacity went up enormously. And to the point where our waiting list went down to about 3 weeks at one stage. But now we're kind of almost back to our normal referrals. And the challenge became, how did we get our staff back from redeployment and also to increase theatre capacity? So we started the 6th of July. We started getting our implants back. After quite a lot of arguing, we argued quite a lot that many of these patients were referred from outside. Many of them had been waiting a long time, and they were beginning to develop quite serious psychosocial comorbidities. And they eventually, we got about 1 theatre back, then became 2, and then back to 3. And what you may even, I'll show you here, was that we then had a sort of pathway which modified a little bit from our usual pathway, in that we did a telephone triage. Now, one of the things is that we saw a lot of patients from outside London.
David, you got slides to show?
You have slides to share, or?
Yeah, is this slide not shared?
No. So if you just start sharing your slides.
Oh, sorry guys. Let me go all the way back then.
Just share it from where you left, because so far it was quite reasonable.
Yeah.
Right, have you seen them now? Ah.
You can see them nicely now, yeah.
Ah.
Just go into the slideshow now.
Right, do you know what? Right, once the, can you all see it? Sorry.
Yeah.
Let me go through quickly. So you don't need to see this. You've seen the sort of 4 pillars and what we did existing and lockdown, new referrals, and this is our pathway.
Yep.
The other thing about what's going to happen if we get this vaccine, I'm uninstalling Zoom. So we start off with this telephone triage. So we see a lot of patients outside from London who live quite far, and we employed the implant coordinator he's actually been with us for about 2 years now, but he got a lot of information, especially a lot of letters, scans, and GP logs, so that we can get an information. Are these patients worth coming in? So when we started the service, we actually brought people in face to face. It wasn't all telemedicine. And then when we had the decision to bring them face to face, we can then see them with the MDT, including our physiotherapist and psychologist. And again, we used a lot of, one of the things we had in our service was a neuromodulation program, which was residential. Now, we couldn't do that with social distancing, so this became virtual in a similar way to what Philippa had shown. So I'm not going to go into details of what we did. This is, in some ways, a lot of the PMPs are now gone virtual, and we did exactly the same. Now, for the trials, we still do trials. We still had the, we haven't quite gone into on-table trials yet. One of the problems with the on-table trials is that we've kind of gone pretty much paresthesia free for probably over 95 or even more of our cases. And we did these percutaneously. So we moved away from doing tunnel trials, which is our bread and butter, to just percutaneous trials, because we can do them local. And I'll show you later on another way that we got around it. And then once we made an assessment for the full implant, we again did quite a careful risk assessment. When do we bring them in? How do we shield them? How do we take the swabs? And what sort of pathway we wanted them to follow. Now, we struggled with this a little bit. I don't know about other training centres, but we found that our trainees, because they were usually from an anaesthetic background, they were the first to be stolen and away from our service. We also had some pain post-CCT ones, but because they weren't part of anaesthetics, we found it a bit easier to keep hold of them. But we pretty much lost all our trainees. Another part is research. What did we do regarding some of our research projects? Because pretty much unless you had COVID in your title, you weren't allowed to do anything. And the NHR and most of the R&D departments split them into level 1, 2, and 3. And we argue that most of our patients were in level 2, just because of their sort of comorbidities. These were patients with quite a lot of refractory pain that, if they didn't get any sort of treatment, would get worse and worse and potentially go on to doing things like long-term opioids or worsening functional immobility. And again, started at the end of July. So one of the things about how did we get back? Again, this risk assessment, we focused very much on which sort of patients could we bring back safely, and which ones that we keep shielding. I'm not going to talk about telemedicine. I think everyone's kind of gone into that in a lot of detail. And we pretty much used a big arguments about these patients are vulnerable. Pain patients are not like other patients in our trust. They've been seen by lots of different people, experienced a lot of delays, and further delays were going to make them worse and more unhappy. And they bought that. So this is an example of a decision-aided risk assessment, looking at different comorbidities and how long they need to be shielded for and swabbed. And this is green, amber, and red, I think, which is shared by most trusts in the UK. Now, what made us a little bit different was that we broke away from anesthesia. So we're not actually part of the anesthesia department. We're part of a department called medical specialties, which focus on outpatients and ambulatory care. So we had more control of our budget and our staff. So when they asked us to redeploy people, it was more of a joint decision making. They couldn't actually take away anyone without, in some ways, talking to us. The exception was our anaesthetic trainees. And in January, we built actually a pain procedure room next to our clinic, which allowed us to do a lot of our procedures. And this was our own this was kind of our own theatre. We didn't have an anaesthetic machine, so they were only local, but it allowed us to do our percutaneous trials. And this was a real godsend, really, because when we came back from lockdown, one of the scarce resources was theatre. There was just no space, and there was a big fight. But this allowed us to keep our injection lists going. We didn't use it in the middle of lockdown, however. And again, I think Philip has talked about the virtual PMP. So we moved away from a in-house PMP to a virtual one. And we used Blue Jeans as a platform. Zoom wasn't considered by our trust to be secure enough, and Teams was just too clunky. So overview, again, big use of telemedicine. I think even if the pandemic goes over, this is going to stay with us. And I think that's quite a useful thing, especially for patients that live quite far away, or for a lot of our follow-ups where you don't really need to see them face to face. We put a big emphasis on triage to see which patients are able to come and see us and which ones can wait. And I allied that with risk assessment. And also something that we were quite fortunate, we were able to ring fence a lot of our services. And I think a part of that, because we weren't part of anesthesia. Now, not everyone's got that luxury, but we made quite a conscious decision about 4 or 5 years ago to split and to give us a bit more control. Okay, I want to say thank you. Sorry about the beginning. I didn't realize my slides weren't being shared. And if I'm happy to answer any questions near the end, if anyone wants any more details.
Thank you, David. Thank you. I was just waiting for you to load the slides, thinking you want to first do the off-slide talk. Don't worry, but it worked.
I know, sorry. I couldn't see it on mine. It just looked normal to me.
No, don't worry. So our last speaker of the day is Mr. Girish Vajramani from Southampton, talking to us about functional neuromodulation, DBS, VNS, etc., and what impact COVID had on those kind of services. So here to you, Girish. You are on your third slide. I think you just need to go back. Thanks.
Okay, is that clear? Yeah.
Yeah.
Okay. Thanks for inviting me to share my experiences of neuromodulation during COVID times. I'm one of the consultant neurosurgeon at the Center for Functional Neurosurgery at Southampton. I think I'm probably one of the anomalous department where we in fact managed to do more than pre-COVID in terms of neuromodulation. This is just our service, how we have one pain consultant, one pain psychologist. We have 2 neuromodulation nurses, 4 research nurses, and we have 2 implanting neurosurgeons. Of course, my colleague, he doesn't do any percutaneous work, and I give him some paddle work because of my huge waiting list, but it's predominantly me as the implanting physician. 80% of my work is percutaneous, about 15 to 20 is paddle work. So this is the setup that I had before COVID. We had I had 2 a month on-call theaters and 2 a month elective theaters at the main hospital. But what was important was I had a dedicated spinal cord stimulator list at the other hospital, which is the Royal Southampton Hospital. So I had 6 Wednesdays out of 8 in 2 months. That's where I was doing all my percutaneous SCS work. And that was really, really godsend. And this was there for the last 2 years. And that's how I managed to do so many cases, because I'm sure Stana will agree with me that at the main neurosurgical center, it's often difficult to do neuromodulation cases because of all other things that you have to do there. So what happened during lockdown? Of course, all our neuromodulation nurses were redeployed on the ward. 2 of the spinal cord stimulator coordinators were shielding voluntarily, and they refused to come back to work. And in fact, till June 2020, we had practically suspended all the SCS activities, save for some battery changes. Most of the face-to-face clinics were suspended, although we were allowed to do some face-to-face clinics at Spire when NHS took over control at Spire. We had to suspend our MDT. But since June, we gradually restarted the program to start with all virtual clinics and MDTs. We also managed to do the virtual spinal cord stimulator patient education program. So if you see this is the standard COVID curve, we actually started our SCS activity from July 7th onwards. Prior to that, we were doing some cases on an urgent basis, but it's really from July 7th that we kicked off our SCS activity. So the setup that I had post-COVID was in fact much more than what I had before COVID, almost 25% increase in my capacity. So the on-call list, of course, remained the same, alternate Wednesdays. And that is a mixed area for COVID, where I could not do any of the clean cases, would do some urgent neurosurgical cases there. I had twice a month elective list at the UHS in a different theater, which was categorized as the COVID-free area. So I could do some paddle work there. The dedicated spinal cord stimulator list at the Royal Southampton now became every week rather than 6 out of 8 in 2-month cycle. And that again is completely COVID-free hospital. And of course, we were sanctioned a lot of waiting list initiative lists, which again is a sort of COVID-free area. So during lockdown, as in most places, they were concentrating on the cancer and the other tumor work. But once all that was sorted by July, they were really desperate to have more theater utilization. And that's where they gave me practically every Thursday a dedicated SCS list at the Royal Southampton. So these are the number of cases that I've done since 7th of July. We did 65 high-frequency spinal cord stimulator implants. This includes both stage 1, stage 2, and the full paddle implants. We did about 18 DRG SCS implants since July. We did about 4 conventional spinal cord stimulator implant procedures, about 3 occipital nerve stimulator implants. My first DBS since lockdown is on 18th of November, in fact, next week. As a precursor to DBS, we did a thalamotomy just to do a dry run to see whether we can do this or not. It's mainly to do with how well we can coordinate with the radiology department for stereotactic scans, etc. My colleague who now does all the vagal nerve stimulators, he managed to do about 5 new VNS cases, but another 5 or 10 battery changes since the lockdown. So these are the cases that we managed to do. I think I just sort of summarized this into the SWOT analysis. So my strength was really, I had increased number of lists. And also I had a management that was really keen on the recovery plan. In fact, our trust was liaising with NHS England to come up with a NHS recovery plan for all the elective cases. And we were really, really interested and keen to get this recovery plan move forward. So as the management was keen and I had a huge waiting list, they were really keen to get my list sorted. Also, the other thing that we did was we moved the SCS from a planned pathway to 18-week pathway. But it's not really a true 18-week pathway. It's from the time we decide that this patient is suitable for SCS, from that point onwards, implant has to be done in the 18 weeks. The advantage of that was, of course, whenever you have 18-week pathway, it gets flagged up, whereas a planned pathway is more like a black hole where the trust is not interested what's happening for those patients. So it was, in fact, it's good for me that these patients have now moved to 18-week pathway so that I could, the management is keen to give me more theatre space, etc. Weakness, of course, all this comes with, you need to make sure that the morale of the team is high, because during lockdown, everybody's morale was pretty low. And then when we kickstart this service, we had to ensure that all the staff are adequately, counseled and make sure that everybody is happy that we are doing more and more number of cases, because ultimately it'll be more activity for the nurses the more cases you do, because they have to do all the follow-ups by phone and also see them for the end of trial reviews. So I had to ensure that the whole team was psychologically prepared to proceed with the SCS activity full steam. Of course, the threats are that there's only certain number of lists that I can do. I can't be there everywhere, every day operating. There are disadvantages to that. But for now, I've reached a level where I can work with the theatre list that I have. The opportunities are, of course, if this becomes the norm, if I can get these regular dedicated SCS lists. Of course, I didn't tell you that I have the dedicated list now at Spire as well as a part of NHS work. So I can do my paddles either at Spire or the UHS, whereas all the percutaneous work I would do it at the regular list at the Royal Southampton. So how are we in terms of second wave? Of course, we are much more prepared during second wave compared to the first one. Currently, as far as I can see, there's no impact on my elective activity. The trust is still keen to continue with what I have been doing, but there is likely going to be a gradual reduction in the elective theatre capacity across the trust, which I fear may have some impact on my activity. But I was told that it's not going to be a precipitous reduction in the theatre capacity, but it's going to be a gradual reduction. And when the lockdown ends, it's going to go back to normal. We have, of course, been doing Zoom clinics. Well, not Zoom, we use Attend Anywhere. We have been doing a patient education session on Zoom, as well as Microsoft Teams. We have been doing both face-to-face as well as virtual joint clinics. We have been doing the neurosurgery pain MDT on the Microsoft Teams. So I think we are much more prepared this time compared to last time. But, I think probably because of all these factors that the trust was keen to reduce my waiting list, and we managed to get this extra list at Spire as well as Royal Southampton Hospital, that we managed to do so many cases, which I think it would have been difficult if I was just operating at my the base hospital at University Hospital, Southampton. Thank you.
Right, thanks, Girish. so we're going to try and have some discussions now, guys. And I think we've got a couple of questions from the audience. The first question is to Philippa. We'd like to be interested to know which disciplines are involved in the delivery of your virtual pre-SCSM PMP. I'm just going to try and let everyone know that there is a possibility for you to put your hands up. One of the things that we wanted to have tonight was to have a discussion about how people are doing things in different parts of the country. Is there anything people are doing differently that we've not covered so that we can learn from each other? And also to see if there are areas where they're not really started, whether this discussion would help in kind of getting some plans about how to move forward. So with that, I'm just going to start with the first question to Philippa.
Okay, well, straightforwardly, we have an occupational therapist, a nurse, a physiotherapist, and a psychologist attached to our spinal cord stimulator team.
Thank you. Girish, there's a question to you saying why you got this high number of HF10 implants compared to conventional SCS.
I think it's purely based on the clinical grounds. If the patient has severe back and leg pain, I go for high frequency. If it's pure leg pain, we do the conventional one. So it just so happened that these were all back and leg pain patients.
Right, so we got 37 attendees today, and I'm hoping that you could either put your hands up or be able to, I think we're figuring out, because this is somewhere where there's a Q&A function. Can I ask if anyone got anything that you do differently that you'd be able to talk about? And I think I just need to see how we could get you to talk. Jenny, is there anything on your host that you can actually ask someone to talk? Or if can the candidates actually put their hands up?
Yeah, so the attendees should have the function, should have the ability to virtually put their hand up, and when they do, I can see it. I should be able to see it this end, and I can allow the individual to then talk.
Right? Is anyone willing to put your hands up? Otherwise, I'm going to name somebody. So does anybody do anything differently to what you heard, guys? Complete silence.
No volunteers are present.
I'm going to volunteer Abdul now. Abdul, do you mind putting your hands up and let me see if I can get you to talk? Maybe they don't have the function.
Yep, Sarah Love Jones.
Go for
Here
it.
we go. Okay.
Perfect. Go on, Sarah.
Well, I'm really just answering just so that you can try it out, because I felt sorry for you. But actually, no, seriously though, we carried on with our clinics in Bristol. We didn't cancel any clinics, but we carried on with them all virtually or telephone, so either video or telephone. We unfortunately I lost my theatre list, and we lost all the other pain anaesthetists lost their injection lists, and we still haven't restarted. I've done a couple of lists that I've been given cancellations ad hoc, but I still haven't got my theatre slot back. So, and I think I'm probably one of the last ones. I did ask a few of you before, thanks for answering, because we're fighting with the management to try and get our list back. And I think literally just before this last lockdown, they've said that they can accommodate me in theatre, but I don't know whether that's going to happen. We carried on all our pain management programs via Zoom, actually. They managed to get permission to use that. And actually, a lot of the patients prefer virtual pain management programs than actually coming in. So that's been a great success. And like some of the speakers, we'll probably continue with a lot of our outpatient appointments on the video platform.
Thanks, Sarah. Right, any more?
Can I just say that one of the things that I was told when we were re-establishing services was that because we'd never stopped doing something, it actually made it easier for us to restart again. It's something to do with some national guidance that was being put out that you couldn't reinstate services until they'd got the go-ahead from NHS England. So if we'd actually, we were fortunate in the fact that because we'd kept something going, that allowed us to kickstart a little bit faster than I think some services who had been very good at sort of standing aside for that first few months, then found it very difficult to reinstate. There was a big inertia getting them going again.
When we had a similar, go on, David.
Yeah, just a point. In some ways, what I find it a bit sad that a lot of pain management departments got hit quite badly during the lockdown because you had to redeploy a lot of the staff. Most pain specialists are anaesthetics in background, and because we weren't part of anaesthetics, we kind of used this as a bit of leverage to say, look, we lost a lot of our services. We helped you out, and they gave us some little bit of a slack back from getting our theatres, because we were in danger that we weren't going to get any theatres back. They would easily say, look, all the private hospitals are full up with doing cancer, a lot of social distancing, a lot of the theatres stayed as emergencies, but we said, look, we gave you our staff, we need something back. And I think to be kind of, in some ways, get hit twice is actually quite unfair on a lot of the pain services.
We were fortunate in Leeds because when the services in the private sector was open for NHS, and initially it was 100% work. So we actually started our implants in June. In fact, we've got the same experiences, Girish has. We had more capacity during this lockdown period than what we had before. So we did approximately about 180 to 190 episodes for implants alone. So we managed to keep up with our waiting list, which has been really good. I mean, in fact, I think we've done quite a bit more in this period than what we normally would have done with the annual leaves and study leaves and so on and forth, because nobody went anywhere. So all the lists were completely filled up to maximum. But I think that's a very positive experience for us because we actually put our hands up right at the beginning to be on the private sector on the green working zone. So
Bharani, there is another question.
Yeah.
Does anyone think that their practice will change post-COVID as a result of the experience that they gained during the COVID? Yes. Can I answer this? Because one of the things that had changed in many implant centers is going away from doing a two-stage procedure to a single-stage procedure with on-table trial for cases where it is on-table trial is required. And this was a combination of being forced because of the COVID and also as a result of the trials team study results. So I think I will imagine that in future, many centers will go on to doing a single stage implant. And I will invite comments from rest of the panelists if they have anything to add to it.
I mean, it's a cultural change, isn't it? Because you've always used to doing a trial. And if you are from a unit where trial is a mandatory, you would find it very difficult to do a transition. And once you transition, you realize actually, if you've got a success rate of 90% plus in conversions, the interesting bit is some of the patients who don't have a decent trial would still do really well at 6 months. And that's what we've noticed. I mean, we've just completed a study on patients with no previous back surgery. And we actually included 30% improvement as the study criteria because these were really difficult to treat patients. And I just wanted, because it was a pilot study of 25 patients, so we wanted to make sure that we captured everybody. And what was interesting was that the amount of pain relief and the improvement in the ODI is more or less the same, whether they had 50% during the trial period or 30% during the trial period. And the question is, we missed that 0 to 30, so we don't know what they would have done if we carried on implanting them. So I think more and more looking at it, maybe we talk about this false positive and true positive, false negative and true negative. It's a transition. Once you move on to that transition, you would be able to do it. I'm not saying that you probably would be happy to do 100% of your cases, because there are going to be some cases which are not a routine, straightforward patients. So you would want to really test those people. So we still do trials, but it's a very, very small number. And we've always done that even before COVID. So for us, I think there was not a huge change. But other units, I mean, for example, Philippa's just started doing that. So if you ask Philippa, would you go back to doing trials for all your patients?
No, we were always quite keen to move towards a no trial or trial on table. So we were I was watching the and waiting for the trial stims to work to come out, really. And this just gave us an opportunity just to make that decision. We'll still offer some patients have said to us, oh gosh, I'd really like to have a trial. And we have said to them, well, that's still possible. You can do that if you wish. But yeah, I think from a service provision point of view, it's far more efficient, and there doesn't seem to be any great benefit for doing the trial from our point, So yeah, we'll move, definitely. I think we'll also do a lot more telephone follow-up clinics as a standard, and we may provide a lot of our information virtually still. How much of I think it would be ideal if we could have an SCS program that had at least one face-to-face group at it. A lot of the patients have said what's nice about the virtual thing is that they can invite their family and friends to listen in as well. And we've always been really struggling with space for that when we've done it on a face-to-face basis. But obviously, when they're online, anybody can listen to the information they're being given if they chose to share it with them. So that's been a benefit, and we'll stick with some of that as well. I think a lot of the information we provide will still go out virtually. So
just out of interest, Philippa, you mentioned that you've developed a YouTube video. Is that something you'd be happy to share with this team? Just on our, I know it's a closed video. Is that something you'd like to share with the rest of the team? Because we've developed one, and that's nearly 2 hours, and we are struggling to cut down the content. But if you've done it on 2 minutes with 5 videos, that's like 10 minutes. That's pretty good comparing to what we've developed. So I just wanted to, I mean, it might be...
Sorry if I misled you. There's a 2-minute introduction, and then there's 4 other videos. I'm not quite sure of the length of those, but I can also always ask the star of the video if he'd be willing to share them. I'm not sure if Dr. Hall's still on, but yeah, he's the one who's actually done the video, and I'm sure he'd be happy enough to share them with anybody if they want to see them.
So another question from Germany, Barani here.
Yeah, I've seen that. Georgius is just asking us whether we changed companies. To be frank, in the TNT study, or the trial, not to trial study, we did not have any specific companies. It was 3 centers which took part, which was Leeds, Middlesbrough, and Basildon. We implanted what we'd normally choose to implant. So we had a combination of conventional stimulation, burst, high frequency. So in essence, even now when we don't really need to get an on-table paresthesia coverage. The idea is if you're using a paresthesia system, you want an 80% plus coverage on the table. If you're using a non-paresthesia system, how you place them, you need to do that. So in essence, if you're doing a paresthesia mapping for a non-paresthesia system, you need to get that on table. And if you're doing an anatomical placement, you need to be happy that your lead is anatomically in the right place for you to carry on with the treatment. And that's just exactly how we did the study. And that's how we do our current full implants also. So if somebody's getting a non-paresthesia based system, they just anatomically place right. If you're happy with it, we'll go on and implant it.
So Varani, at the moment, there are no hands up. So I'm just going to ask, kickstart some discussion on intrathecal drug delivery, some points that
Before that, I wanted to say one thing. We all talked about how we do the implant. But one of the things that we also found is the face-to-face capacity for those people who have the implant to come back in for reprogramming, for wound checks, all these things. So we organized for video consultations at 2 weeks for wound check. So in essence, the patients will just basically show their wound, make sure that they ask the appropriate questions to make sure they haven't got any signs and symptoms of infection. So the patients never even had to get out of their house, so they could just have a virtual consultation for wound check. When we did the programming, we did as many programming as possible, so we don't want to bring them back to a hospital setting. So any system that we use, we actually utilize the maximum number of programming that you can do with that system. And we had then do a telephone consultation or a video consultation at 6 weeks to see how they're doing, and then run through the program virtually so that they don't have to come back into the hospital for further programming. The only plan is to see them at 3 months. And I think we've only just about started seeing patients who were implanted in June. So that has helped the footprint into the hospital for face-to-face appointments. Go on, David.
Yeah, just a couple of points really. I wonder if there's any chance that programming could be done remotely.
It's not possible at the moment, but there are companies which are working on remote programming, and I think this COVID would help in getting this up to speed, I think. So yeah, I think if there's any industry team present, which I know there are quite a few, please put your hands up if you think that technology is going to be available with your industry very quickly.
Yeah, because one of the things we had was...
We also got a message from Peter Hall to say that he's quite happy to share that link for people to have a look. Thanks, Peter. Yeah, go on, Ash. You can ask about intrathecal.
Oh, yeah, so Stana did mention a problem about supply of drugs and the concentrations that are for intrathecal drug delivery. We had similar problem, but interestingly, we had problems with baclofen supply rather than opioid supply. So it was number of times we had to change the baclofen concentration in the pump. One thing we did was we opted to have wherever possible, highest possible concentration of baclofen in the pump so that we can delay the refill interval, especially for some spinal injuries patients who are on quite high dosages of baclofen. But that did raise concerns about changing the concentration of drug at every refill. Fortunately, the new programmers make life a lot easier to adjust the bridge bolus and make things error-free. But you raised interesting points, Stana, about having some kind of network, like the way the nurses have their network. And my observation is the ITB forum works quite independently of NSUKI, and there isn't much interaction between the implanters, the anesthetic or pain background or the neurosurgical background of implanters, pump implanters versus people who manage those ITB pumps around the country. And whether having a Google type of group or a WhatsApp group of clinicians who are integrated under one umbrella for managing these services. And if you had problem with opioid supply, while we did not have that problem, but we had problem with baclofen, can we have actually a network of pharmacies that supply intrathecal drugs for refill of the pumps, will then sort out this kind of problem nationally? What are your thoughts, Stana?
I think it would be good. I think that there are lots of networks, and the individual networks work very well at individual levels. So the nurses have a really good network. If you have a question of, oh, look, if this person's moving region, who could take this on? The pharmacists have a more limited network, but I think it would be really great to have a network of everybody on the team being able to ask questions and help out with any question at any level, not just refills, implants. If people aren't able to do an urgent pump change, where's the nearest place they could go to? Who can help out? And as you say, the same thing with with refill medications, so that if it involves the whole team, it would be really helpful. I think the thing about COVID, a comment I would make is there always needs to be a silver lining, doesn't there? And the silver lining for COVID is the NHS works very slowly with regards to change. It has made us have to review the degree of change and the amount of time. So all the things we've discussed about telemedicine was happening slowly. It's now happened more quickly. I think for the companies, remote programming needs to happen quickly now. And I think those things are positive. But I think a network for ITDD would be great with everybody involved.
Sure. Let's see. As NSUKI,
That'll be your first job, Ash.
I know. I have pulled it on me, isn't it? But I think it will be useful for everyone involved.
So if there's, I've not seen anybody put your hands up. And I think our webinar was, oh, David, go on, sorry.
Yeah, I've got another practical point, and it's, in some ways it's for everybody. So what do you do in the lockdown when you have a complication with your implants? For example, infection, CSF leak, or even intrathecal pumps. The neurosurgeons have the luxury of an on-call team. Do you have that in your pain team, especially if the consultants are redeployed to intensive care? It wouldn't be really fair for them to then deal with, say, a problematic implant.
I think this is two phases, David. One of them is, I mean, I don't know about other hospitals. We definitely have an on-call rota for implant and intrathecal pump. And that is between the 4 pain consultants. So we do 1 week at a time. So when we were redeployed, we were still available on that rota to be contacted if there was any problem. The fortunate thing was our redeployment was between March to kind of middle of April. And when we got redeployed, we were into groups doing ICU. So we made sure that each group had one pain specialist, so that if the demand wasn't there, we step out very quickly. So we managed to step out within 3 weeks because the demand wasn't there, and we started resuming our services for outpatients. And I've never seen an outpatient clinic similar to what we have now, which is the patients are seen within 2 weeks, because that's how much we've cleared our outpatient backlog. Whereas the on-call still stayed 1 in 4. When the patients had any problems, such as infection, we had to deal by bringing them into the acute services. And I think, as you rightly said, it has to be within the neurosurgical or spinal services, whichever link that you have. And if you work in a hospital where there's no neurosurgery or spinal services, then you would have to liaise with the normal team that you'd liaise with, such as a general surgical team or whichever services plastic team, whichever you use to do. So in essence, if there is anybody with needing to go back to theatre, we utilize the spinal services. If this was something which was kind of maybe infection needs to be looked at, then we tend to try and keep them on our elective list for evaluation and treating it appropriately. I mean, sometimes we do washouts. So I think I've done 1 washout in this period on my elective list, and we've saved that implant because this patient refused to have the implant taken out. So that is a possibility. So it all depends on where you stay, but we've always had on-calls for the last 15 years or so.
So David, important thing is that if you are redeployed, we always made sure that there is at least 1 implanter who is looking after all these implants. You cannot have the whole team redeployed into anesthesia or intensive care, because pump is a hard work, including stimulators. And you can't just give it to the on-call neurosurgical team if they are not part of your multidisciplinary team. If they are not familiar with the implants that you are doing, you just can't give the on-call neurosurgical team to sort out your and my problems. So at NSUKI, we made sure that at least 1 implanter is always available if the rest of the team gets redeployed, and we kind of rotate between us.
So we got somebody who's put up the hands. Tim Palmer has got his hands. Jenny, are you able to let him in to talk? Excellent. Go on, Tim.
Hi, Bryony. I was just responding to your question about industry and comments on remote programming, really. I think we discussed it a little before, and I obviously work for Saluda, which is one of the smaller companies, and there's a lot more capability in the larger companies on the market. But the technology is definitely available. It's definitely possible. It's something that's been done in cardiac devices for at least 10 years now, from a remote follow-up point of view. But that's more just downloading information rather than programming from a distance. And I think that the big challenge that everybody has is the regulatory approval to be able to program a patient from a distance. So I know that
this is the right time, as Stana says.
Yeah, I agree. I think. Yeah, I think I don't think it's a big secret that everybody or most companies will be working on this. I just don't think it's something that can be. I guess it's going to be done quicker than it ever was before, but it'll take a bit of time for everybody to gain approvals. And there's probably an opportunity for a collaboration with industry and the likes of NSUKI or INS to try and help this process, because reimbursement will also be something that needs to be arranged as well. I know that was an issue for a while in cardiology. but it's possible. It just needs to be expedited, I guess, now.
Thanks, Jeff.
Thank you.
Right, if there's no more questions, I saw Manny put his hands up and then it went down very quickly. Manny Mander, do you still need to ask a question, or was that just an accidental press? Okay, he hasn't got his hands up. Right, okay. Ash, do you have anything else, or should we just, I mean, we're 5 minutes over, so I'm quite happy to try and close if there's no further questions from anybody.
I'll take 2 more minutes on another point on intrathecal drug delivery. Stana did say that they didn't do any new test dosages or any new pump implants during this problem. Well, not during this problem, but during the COVID peak of first wave. At James Cook, what we did was, for cancer patients, we know generally this works. So we went away from doing a test dose and we just implanted these patients so that, you know, you are not denying them of good pain relief that they deserve just because you can't do the trial. So we did a handful of patients where we did direct implants of pump and then titrated them once the pump was implanted, because we know it does improve. It has got a lot of positive things. And similarly, we did a couple of patients with spasticity for direct implant without doing a baclofen bolus, where we were convinced that this is spasticity and not contractures. And rather than bringing them back and forth, we just went straight ahead with full implant without any trial. That was just the one comment for what we did differently.
I hope you're not going to carry on with that.
Well, hopefully not, you know, but, you know, all of them are working quite well, you know. It is all about patient selection.
As I said, it's all about habit, isn't it? If we've been doing things in a certain way, we don't like to change.
Absolutely.
Change is difficult.
Well, Ash, it's a good point, because I thought it just happened we didn't have any referrals for cancer over that time. But the last couple I've done, I've just implanted them.
Yep.
Because you just think, you know, it's a bit like if you've got a greater than 90% conversion rate for SCS, it's the same argument for that group of patients.
Yep.
And actually earlier this year, I thought, I'm going to do that for spasticity, long chat with the patient.
Yep.
And he was my first patient in 16 years that then didn't like the effect. So he's the only patient I have ever done an implant on who hasn't liked the pump, because it worked too well. So it's interesting, isn't it? But you've got to sometimes try these things to move forward.
Absolutely.
And ask the questions.
Yeah.
Right, okay guys, I hope that was useful, and I think I have actually recorded this, and my plan is to try and put it up in the NSUKI website again. So if people haven't been on tonight and you want to pass it on, we should be able to do that through our Google group and various other communication channels, our NSUKI membership and BPS membership. So we will try and do that. As Ash mentioned, on the 23rd of November, there's quite an interesting talk on how we could do placebo-controlled studies with spinal cord stimulation. So if you're interested, please register, look out for the link that is going to come soon. We also think that our annual scientific meeting for next year would be along with the European INS meeting in Paris. And the date for that is the second or third week of September. I can tell you the exact date. Yeah, it's the 1st of September to the 4th of September. So NSUKI's annual scientific meeting should happen in hopefully face-to-face with the current advertisement on Pfizer finding some cure. So hopefully we will have a face-to-face in September 2021. But meanwhile, we are hoping to try and do more webinars. If there's any subjects that people want to really talk about, kindly feel free to email me or Ash, and we'll be quite happy to try and pick it up and put up a webinar in the evening for about an hour to 2 hours. Thank you.
So thanks to British Pen Society for helping us to run this webinar as well. Thank you, Jenny.
Thanks, Jenny.
Thanks, Jenny.
Jenny.
Thank you to all the speakers, guys. Thank you very much.
Good night.
Thank you.
Good night.
Thank you.
Cool.